Good morning. This is Swami Iyer. We are the third day of SOHO in Houston. I have the great pleasure of introducing Dr. Bob Orlowski, a professor and the chief of myeloma and the interim chief of lymphoma in the department at the MD Anderson Cancer Institute. Welcome, Dr. Orlowski.
Well, thanks for having me very much, Swami.
So you were one of the two chairs today at the myeloma presentations. It is outstanding as always, and some of your impressions sitting there as a chair with the presentations from Dr. Jagannath and the newer ways of looking at myeloma from Dr. Shaji Kumar and the newer drugs. So could you sort of give us your impressions, and then we can get back to what it means to day-to-day treatment of myeloma?
Sure. Well, thanks again for the opportunity. I think first of all, what's important to know is that we have new definitions of what is myeloma that should be treated versus what is myeloma that we can still do a watch and wait approach in the smoldering setting. In the past, we used to only treat people who had the CRAB criteria, meaning hypercalcemia or renal insufficiency or anemia or bone lesions. And the problem is that we've learned in the past now that we have some people who are at very high risk, up to 80% of progression within 2 years with smoldering disease. And because, of course, the progression events can lead to really serious medical events like renal failure, the feeling has come along that we should really be treating those people. So the three new categories that have been added, and these are now people who are symptomatic and should be treated, even though previously they would have been considered smoldering, are people without the CRAB criteria, but if they have 60% or more involvement of plasma cells in the bone marrow, or if you have bone lesions, more than one focal lesion on magnetic resonance imaging, or if you have an involved to uninvolved free light chain ratio of 100 or more. So these people should probably be treated with induction chemotherapy because their risk of progression is going to be very high.
Obviously, you're going to all meet in Rome in a week to consider this and ratify this, I would think. In trying to do this, so I guess you're suggesting that many of these patients should have all the workup that you normally do for myeloma, including an MRI, so you identify those high-risk patient population right up front.
Definitely. So if you have a patient with otherwise smoldering disease, we would recommend that you do things like get the free light chains, which most people probably do already. Of course, the bone marrow is part of the standard of care, but also think about MRI in terms of looking at the spine, and there are some places where you can get an MR-based bone survey that can be helpful as well. And I think this is an area to watch because there are new criteria that may come up in the future as well. For example, we know that people who have more circulating myeloma or plasma cells in the blood are at higher risk of progression than people who have fewer. So I think these diagnostic criteria for who should be treated are going to be evolving further over the next few years.
And it's finally, I think we have a definition because a lot of questions that the community oncologists ask for what to do with these patients. Of course, we also have data in terms of treatment, at least from the smoldering myeloma. I think there are many studies. Obviously, when you say induction treatment, would you treat them like a multiple myeloma, like any other multiple myeloma, or would you look at them differently?
I think for right now, we would probably treat them like any other myeloma patient. And that sort of gets into one of the other themes that was discussed, which are some of the new upfront therapies that are available. And probably most people would argue that for a relatively robust patient, irrespective of age, a 3-drug combination could be considered, combining a proteasome inhibitor with an immunomodulatory drug. Right now, the most robust data are with the combination of bortezomib, lenalidomide, and dexamethasone, and there will be a presentation at the American Society of Hematology of a SWOG study that compared Len-Dex to bortezomib Lendex as an upfront induction, which will be the first phase 3 data with the VRD combination as an induction. And then another combination one could think of would be with carfilzomib, lenalidomide, and dexamethasone. Right now we don't have phase 3 data for that in the upfront setting, but the ECOG folks are running a trial for newly diagnosed patients where they're comparing KRD to VRD as an upfront therapy. That would be probably in general for transplant eligible patients. If you have transplant ineligible patients, then the best study that would guide therapy would be the so-called FIRST study, where lenalidomide and dexamethasone was given continuously in one arm versus Lendex for 18 months versus a third arm of melphalan, prednisone, and thalidomide for 18 months. And the winner in that, clearly based on progression-free as well as overall survival, was lenalidomide and dexamethasone given continuously. So right now for transplant ineligible patients, that would be the standard of care. And I think the excitement is about the upcoming monoclonal antibodies, because we know that lenalidomide really enhances the activity of some of these drugs like daratumumab and elotuzumab in particular are furthest along. So looking, say, 5 years down the road, I think for transplant ineligible patients, we'll probably be treating them with Lendex plus one of these monoclonal antibodies.
It's outstanding, the array, the a la carte menu, if you will, that's available for myeloma patients is just getting larger and larger. But if I may persist on that question on the patients who are transplant ineligible and the first study, which showed the continuous dosing, one of the misperceptions, as you know, in treating these patients is you treat them to a certain response and then do nothing or have some kind of maintenance with one drug. And what is clearly seen in this study was the PFS advantage, and counterintuitively, it is not as toxic as the MPT, which is the other standard. So obviously it has changed the way we look at things in these patients. And any other points that you want to add for those people who are just treating them to a certain response? Because the response didn't really correlate with the PFS, even though VGPR seemed to do so.
I think the other thing to mention from the first study is the second primary malignancy issue, because with the lenalidomide maintenance after transplant studies that the CALGB and the French did, and also the study that was done in Europe looking at melphalan, prednisone, and lenalidomide, followed by len maintenance, all three of those large randomized studies had a small but reproducible increase in second primary malignancies for patients who got the lenalidomide maintenance. And of course, the last thing that we want to do is have second primaries. But in the first study, which did not use alkylating agents, there really was not an increased risk. So there does seem to be something particular about either combining len with an alkylating agent at the same time or giving len shortly after, for example, high-dose melphalan. For these patients who are not transplant eligible, SPMs weren't a concern.
That's a very good point you make, so to be aware of second primary malignancies when you combine it with melphalan. So if coming back to the transplant eligible patients, and I think we would all agree that the best bang for the buck is right up front when you try and plan out a strategy for these patients. And you talked about some of the induction opportunities with the ThreeDrug regimen, and there's plenty of data, including the upcoming SWOG study and the ECOG studies. So how do you plan what to choose? Of course, if a clinical study is available, you would have the patients go on studies. But for those folks who don't have clinical studies, your standard would be to do something like a Velcade RevDex?
I think that probably right now the most robust data that we have are for bortezomib with lenalidomide and dexamethasone. It has virtually a 100% response rate. The breakdown seems to be that about a third of patients get into a complete remission, about a third get into a VGPR, which means a 90% to a 99% reduction, and about a third get into a PR, which means between a 50% and a 90%. Of course, we'd like to improve upon that because we know that if you're in a CR going into transplant, you're going to have a better outcome afterwards. And it may be that with addition of a monoclonal antibody to that combination, or maybe by adding carfilzomib instead of bortezomib, you may get a deeper response, although we don't know the answer to that question yet. So I do think that right now VRD is still an excellent standard of care. And of course, some people like to use cyclophosphamide with bortezomib and dexamethasone or Cybord-D. In general, the data would suggest comparing across different studies, which of course is not fair to do. The data in my mind suggests that they're both excellent, but probably VRD would win by a nose in terms of response rate.
And obviously, that being said, the next steps in the patient's progression strategy is to do a transplant. And I think Phil McCarthy presented the data on transplants and early versus late, and it's clear, at least now, the way it stands, that we send everybody until the French DFCI combined study gives the answer otherwise.
Yeah, so it's a great point. I think in the past, when we've done studies looking at early versus delayed transplant, and Fremond and his colleagues are probably the best example, it seemed that overall survival was really not different as long as you didn't delay the transplant until the 4th or 5th line. If you gave it at the time of progression on frontline therapy, the outcome was similar. The study that you mentioned that the French are doing and that also the Americans led by Dana-Farber are participating in is readdressing this same question with the novel regimen of VRD. We won't know the answer to that for a few years yet, although the French experience may be presented later this year. But the French side of the study was designed a little bit differently than the American side, which is why the US data won't be around for a couple of years. I still think that until we can show that the upfront chemotherapy alone approach with no transplant is superior, which so far we have not, that transplant does need to be part of the standard of care. I think looking forward, one could perhaps hypothesize that if with induction therapy you get into a molecular complete remission, for example by next generation sequencing, then maybe storing stem cells and doing some kind of maintenance would be appropriate, because probably molecular CR is the first step to a cure. But that's still a hypothesis. We don't know how many molecular CRs we're getting right now. So I do think transplant is still an important part of the standard of care.
Excellent points. And I think speaking about the next generation sequencing, one of the changes that you're seeing in myeloma is in trying to understand the biology. It's a clonal disease. It's the attack of the clones, as Ravi Vij presented today. What's your take on that? And I think one of the ways I've seen the development of therapies is somewhat empirical, but it's worked well with the combinations. But now we're trying to match what we're finding in the molecular heterogeneity with the right combinations.
Yeah, definitely. The point that Ravi emphasized is that unfortunately patients with myeloma don't just have one type of myeloma cell. Even though their disease probably started with one abnormal plasma cell, which you could call a myeloma stem cell or myeloma initiating cell, whatever terminology you like, these cells do evolve over time, and you have several different clones in each patient. I think one of the best examples that he gave is the fact that some patients come in and have more than one M protein, which probably is coming from different clones of myeloma cells. Right now, we're not able to say clone A should be treated with drug A and clone B should be treated with drug F. But we're hopeful that in the future we'll be able to go in that direction. But the fact that there are different clones is one argument that is made in favor of combination therapy. Because if you only give one drug, the chances are that there will be different sensitivities among the clones. If you give combinations, you're more likely to hit all of the clones at some level. But I think 5 to 10 years down the road, what we hope to be able to do is, as you mentioned, do, for example, next generation sequencing determine based on the abnormalities in each of the clones what drug combination will be best, and then literally personalize the therapy for patients so that they will not get sort of the generic myeloma playbook. They will get exactly the combination that works best for their set of myeloma clones. And that may be a 4 or 5 drug combination in the future. Or it may be that we'll have to do some sequential therapy where we do one 3-drug combination and alternate with a different 3-drug combination, because although 5 drugs should be more effective, we know that 5 drugs are probably going to be more toxic. So at some point, we're probably not going to be able to keep adding more and more drugs. Although I think the antibodies are really exciting because they seem not to add a lot of toxicity.
So can you speak a little bit about the antibodies? Sagar Lonial had a very nice presentation, and it looks like the FDA is reviewing the data right now with both the daratumumab and elotuzumab.
Yeah, definitely. So Sagar's led a couple of those studies, and daratumumab is an anti-CD38 antibody. It's effective as a single agent in very heavily pretreated patients. These were folks whose disease had previously progressed on both bortezomib and lenalidomide, or they had progressed after 3 prior lines of therapy. The single agent response rate was around 30%, which is really quite good. And we already know that if you add lenalidomide and dexamethasone, that response rate goes up to about 60 to 70%. So that drug will have even better activity in the future in combination. The single agent data are being reviewed by the FDA, and we're hopeful that either before the end of this year or by the beginning of 2016, DARA will be approved. And then he also presented data about the combination of elotuzumab with lenalidomide and dexamethasone. And that's data that were published in the New England Journal, which showed that the 3-drug combination had about a 5-month improvement in progression-free survival. I think the really exciting part about that is that there were quite a few high-risk patients on that study with deletion 17p. About 1/3 of the patients on both arms had deletion 17p. Those are people whose disease usually is more aggressive and doesn't respond as well, and the elotuzumab helped those people as well, which is very exciting because we hope that immune therapy won't care about the chromosomes inside the myeloma cell. All it will care about is whether the antibody against which we're using, that the target for that antibody is expressed on the surface of the myeloma cell.
Excellent, and as we're looking forward to that. But until then, you spoke about high risk, and so far for the high risk patients, at least post-induction transplant, the maintenance approaches that are being used include the role of bortezomib or lenalidomide in this setting. And of course, there are pros and cons about using these agents in a prolonged situation, and there are other exciting drugs. So what is your take on the maintenance part, given the subclones and the possibility of eradicating those subclones?
Yeah, the great question. And because high-risk patients are fortunately a minority, depending on the way you define it, we're probably talking about anywhere from 15 to 25% of patients. That's both good and bad. The good part is that because high-risk patients don't do as well, we certainly don't want all myeloma patients to have high risk. The bad part is that because there are fewer of them, it's a little bit more difficult to do the randomized studies that are needed to validate new approaches. But there is a general consensus that a combination with a proteasome inhibitor and an immunomodulatory drug is important in treating high-risk patients. They seem to benefit less from transplant than standard risk patients, but there are nice data from a study that the Dutch and Germans did, which showed that if you give bortezomib as part of induction and then as part of maintenance after transplant, high-risk patients can do very well. And from Sagar's group at Emory, there are data showing that consolidation and maintenance with VRD after transplant can be very good. So these are people, probably even more so than the standard risk people, who really need to have continuous aggressive therapy. And hopefully what that will do is buy us a little bit of time to better understand the biology so that we can better target deletion 17p, amplification 1q21, 1416, 1420, and some of these other high-risk features. Because right now we're using drugs that work for all plasma cells. What we need is designer drugs, as I like to call them. We need a deletion 17p drug. We need a 414 drug. We need a 1416 drug. And we should be able to arrive at that because we understand a lot more about the biology of myeloma now than before.
Could I ask you, just because you mentioned the designer drugs, you are working on a lot of newer drugs out there. Which one of them in the phase 1, phase 2 setting, including the cellular therapies that you're very excited about?
Well, you mentioned cellular therapies, and of course there's a lot of excitement about chimeric antigen receptor T cells and also NK cells. And we have studies, and hopefully you'll be part of that, Swami, as well, looking at these approaches. T cells are great because they can be taken from each patient individually, modified in the laboratory, and made to recognize just the myeloma cells. NK cells are also exciting because they sometimes can be taken off the shelf without necessarily having to personalize that. We're not yet at the point where that's part of the standard of care, but probably in 2016 we will have open studies in the MD Anderson Center and hopefully at your place. And there are now studies with chimeric antigen receptor T cell approaches being looked at Penn in the context of transplant and also at the National Cancer Institute.
Excellent, and there's a lot of excitement in myeloma, and not only that, you have established ways very efficiently of doing studies, not just in the upfront setting, but also in the relapsed refractory setting, and there was this whole debate on 2 drugs versus 3 drugs in the setting of relapsed multiple myeloma. We are going to talk to them a little later, but what are your thoughts on so far and what the community oncologist would like to take home as a message from 2-drug versus 3-drug once the patient does eventually relapse?
Yeah, well, I thought it was a great debate, and I'll be really excited to see the taping of your show later about that. I think that the 2 arguments that were made, so Dr. Vij showed all of the data which compared 3-drug regimens versus 2-drug regimens and found, of course, that the 3-drug regimens in general worked better than the 2-drug regimens. Then we had a presentation from Dr. Zonder, and the point that he made is that one weakness of the studies comparing a 3-drug versus a 2-drug regimen is that they don't then look at what happens in progression-free survival after the 2-drug regimen is given. And he argued that based on some of the recent data, for example, comparing the high-dose carfilzomib dex versus bortezomib and dex, that perhaps doing RD followed by high-dose carfilzomib with dex would get you the same outcome as doing KRD or carfilzomib-len-dex from the get-go and potentially save money. And I think it was a very compelling argument. It really, though, highlights something important, which is that right now we're not treating people in a biomarker-driven fashion. And what I would hope in the future is that we will understand enough about the biology of myeloma that we'll be able to predict which patient will do fine with just 2 drugs and which 2 drugs versus which patient really needs 3 drugs. That's when I think, first of all, cost of care will go down, because certainly if you don't need to use 3 drugs, 2 drugs should be fine. It should be cheaper, less in terms of toxicity, which is better for patients as well. But we're not yet at the point where we know you can get 3 drugs, you can get 2 drugs with the same outcome.
Thank you, Dr. Orlowski. I think that is a great summary of the morning session in multiple myeloma. It covered next-generation sequencing, the new drugs out there, the different biologies, and of course, I think one of the big burning topics is cost. And I think Dr. Orlowski has given a good summary, and thank you very much once again.
Well, thanks very much for having me.